Hot off the presses results from the first kind of chunk of my dissertation. So I'm basically trying to look at how unmet need for healthcare changes over time in the transition from adolescence to young adulthood. I'm using the AdHealth data set to do that. And so just because, as Dustin knows very well, AdHealth is like a very tricky and annoying data set to work with, I had just been running into a lot of roadblocks with getting the sample sizes to congru and like using all of the weights appropriately so that the data I was getting wasn't like conflated. So basically this is just like the first set of like base models that I feel comfortable standing by, and then there are other things I would like to do to them, but right now I feel comfortable for like the first section of my results just kind of talking about what trends have emerged and how these models display that. So based off the research questions that we were workshopping a couple weeks ago, I decided to stick.
Sarah, I'm sorry for the interruption. Could you blow this up into?
Oh, I'm so sorry. I just started going. So based off the research questions that we were workshopping a couple weeks ago, I decided to use the one I came up with in Fellows a few weeks ago. So I'm basically looking at two sides of an equation of is it possible that adolescent socioeconomic conditions and your transition into a young adult markers like marriage potentially drive unmet need for healthcare, or is it just basic health measures like your actual health behaviors that have been established in literature like smoking and drinking? So I'm looking to see which kind of better predicts not seeking care when it's needed in this transitional period. And so for the purposes of this dissertation, unmet need is when a person does identify that they think they should have gotten care, but then they didn't get care in the past 12 months. So unmet need is actually understudied in this transitionary period. Even though adolescents and young adults we've identified are at least vulnerable to unmet need for reasons including insurance coverage, especially because this sample is pre-Affordable Care Act, but also other issues like youth who smoke and drink regularly are more likely to avoid the healthcare system, according to other literature that's been put out there. So I want to, in this first stage of my dissertation, perform some longitudinal analyses just to look at these trends in unmet need over time, with kind of a focus on what racial and ethnic disparities might exist. So basically, the transition is just a vulnerable time in the life course for health. I'm basically framing this in a kind of defying the assumption that young people don't get health care because they are healthy. While it's true that young adults definitely do often rate their health as excellent or very good, it's also a time for spikes and peaks for acute and chronic health care problems. And this coincides with high rates of being uninsured. So, is it that unmet need is contributing to these problems, or are these problems contributing to unmet need? So being uninsured is actually not the only predictor of unmet need in young people. So other risk factors, if we want to call them that, include being of a racial ethnic minority, high rates of smoking or drinking in adolescence, and then some other things that I might not be able to use the data set to actually also analyze. So we actually don't know a lot about how these things that people are, these risk factors, how they change over time in this age group. There's a lot of cross-sectional data from people who just look at trends for different health conditions or things like accidents and whatnot, but we actually don't know much about longitudinally people's interaction with the healthcare system in this age group, and the people who aren't seeking care even though they identify to themselves that they think they needed care. So I'm going to, in this analysis, use the first 4 waves of AdHealth. The 5th wave just kind of came out, and they're kind of encroaching on late adulthood, middle age at that point. And so I decided to stick with waves 1 through 4. So the actual variable as it's asked in all 4 waves is, has there been a time in the past 12 months when you thought you should get medical care, but you did not? It's a yes or no question. And so they've constructed a very useful race and ethnicity variable that's Black, White, Hispanic, Asian, Native American, and other. They oversampled for populations like Native American, and so I definitely wanted to try and include all categories in the analysis just to see what was in there. So adolescent SES at this moment is mother's education, because primarily mothers are the ones who answered the survey, so we just say mother's education. And the log of household income at wave 1. And then the transition variables is really where the works in progress comes in, because I'm playing with this idea that there are going to be changes in the life course at this time, but that the timing of those transitions is what's really important. You know, it's different to get married at 18 versus 25. It's, you know, different to have a healthcare insurance gap at one age in your life than another potentially. And so I'm kind of limited in some ways by the data, which I'm still trying to refine, which is why I only have ever married longitudinally, but I decided because education is measured a little funky in ad health, because the transition is a difficult time to measure these things in people. I just have their education status in wave 4 in the model at this time. And I had to construct insurance status from, you know, testing if it was reasonable that if you had insurance in wave 1, you had it in wave 2, and if you had insurance in wave 4, you had it in wave 3. Because they don't ask about insurance status in waves 2 and 3, probably because they're like in their early 20s in those waves. And so it might not have even been seen as a worthwhile question to ask them at the time that this data was collected. And then the health measures and general controls are excellent self-rated health versus not, depression scores, ever being a regular smoker, and ever drunk in the past year. Again, this is where it's kind of tricky to measure things that occur in this time frame, because maybe it's not a big deal to get drunk every once in a while when you're 25, but it probably is much more indicative of other risks and behaviors if you're getting drunk, you know, once a month when you're 15. So I've been kind of struggling with how to do that, and in my next steps I think I have a way to refine it, but for now it's just, have you ever gotten drunk in the past year, waves 1 through 4. And then gender, and then the nativity of your reporting parent. So what I'm using for this is general estimation equations. I didn't know how to do this at all when I first started. It's been a very interesting process. And so playing with the what counts as a transition variable and how that might impact the risk of unmet need. The models that I've come up with so far are just a base model with some demographic information, a model that is this, you know, adolescent SES, and then a transition such as marriage, and then a health model that kind of assesses risk of unmet need based off of health measures, and then a full model that includes everything. So this is just like, this is where I'm at right now, because after finally fixing a lot of the issues I've had in the data. So my first hypothesis is simply that the likelihood of unmet need will increase over time as adolescents age into young adulthood, because there are those unpredictable gaps in things like education, employment, and whatnot. As adolescents are trying to establish themselves in adulthood, I predict that unmet need will actually increase over time rather than decrease, particularly just in this age frame. And hypothesis 2 is that racial minorities will be more likely than whites to have unmet need over time, net of controls. I wanted to just kind of make that a blanket statement just because of the scarcity of some of the literature for how that's different for other groups like Asians. So rather than make predictions that might not be based completely in a well-founded literature, I just kind of kept it like that. So related to hypothesis 2, hypothesis 2A is that these transition variables and higher adolescent SES will be associated with having decreased odds of unmet need over time. And then for the hypothesis next after that to be is simply that for unmet need, the relationship between racial and ethnic minorities and whites will be partially accounted for by these transition variables in SES. So the sample is, like I said, oversampled for Native American. It's also oversampled for middle class Black adolescents and their families. And so I decided, again, to just keep all the groups in the models, just to kind of see what would come about, rather than assuming that, whatever results I got would be too low for one group or another. I forgot to widen this bar. But basically, you can just see in this kind of basic line graph is that across waves, unmet need does increase over time. And so by wave 4, they're in their late 20s, mid to late 20s. And so you can kind of gauge that this is a particularly vulnerable time, also remembering that this was part of the issue that the Affordable Care Act was designed to address by allowing children to stay on their parents' health insurance until age 26, which might have accounted for some of this disparity. But it's interesting to see what this looked like before that time occurred. And so then just health behaviors that I found interesting over time is that ever being a regular smoker increases your risk of unmet need compared to people who never report being regular smokers. If you see any particularly kind of big spikes between some of the waves, it's because they weren't consistent with the time that passed between waves. So for example, waves 2 and 3, they were about 4 years in time before they re-interviewed. And so depression, it's a similar story. People who people whose depression score indicates a symptomatology of depression have increased risk of unmet need over time compared to people who do not. So let me deconstruct this for you. Basically, with this model buildup where it's just, demographics, SES, adolescent SES variables and transitions, a health model, and then the full model, you see protective benefits for SES and transition variables for all groups compared to the unadjusted model. And you see similar, but in some cases, for Black respondents, not as much protective effect from having healthy healthcare measures. And then in the full model, the effects for the Hispanic population are attenuated. So while Native Americans and Black respondents continue to have higher odds of unmet need compared to whites, there is some protective effect based off of the health measures and SES and transition variables at this time. So I didn't want to throw a table up there for you, but we can deconstruct what that chart means. So hypothesis 1 is generally supported in that unmet need trends upward over time. Hypothesis 2 is supported in unadjusted models for Hispanics, Blacks, and Native Americans, and supported in the full model for Native Americans. Hypothesis 2A, that these SES and transitions reduce odds of unmet need, is supported. And hypothesis 2B, that those SES and transition variables account for any racial and ethnic disparities, is only indicated at this point for the Hispanic population. So that's basically, this is the bread and butter I have to start with as far as deconstructing what trends are emerging in my data set. Like I said, I kind of just got all of these results the other day when I finally fixed my sample size issue. So I'm still kind of looking through everything and deconstructing, especially the transition variables and how I can make that better. And so in doing that, I'm going to kind of write these current results into my dissertation as, this is the temperature field I was able to gauge first. I'm going to perform some bivariates for unmet need that are available only in ways 1 through 3 where they ask reason for unmet need. And then I've discussed with my mentor, Dr. Baker, principal component analysis will probably be the way to help refine these transition variables so that rather than just having a variable that is ever across the 4 waves, did you marry, did you become a regular smoker, we can actually kind of tease out early starters versus late starters. So then it's more, here's the effects for people who get married early, here's the effects for people who smoke early. And that especially will be useful for variables like drinking, because then I can change the variable to indicate heavier drinking, because then you'll see who's a heavier drinker earlier versus a heavier drinker later. And some of the things that I can't get at longitudinally, I hope to address in a cross-sectional analysis of unmet need, because wave 4 has a wider berth of variables, partially I think just because of the age at this point. Wave 4 is mid to late 20s, and so variables they're asking about income and things like that are more relevant because they're a little more independently established. And they also began to collect biomarkers in wave 4. There's better measures for chronic health conditions in wave 4. So while it might not be possible to track some of those things longitudinally, I think it'll be interesting to look at it cross-sectionally to see how these things are affecting risk of unmet need, particularly because it doesn't seem to have been studied very heavily so far in the data set or in general. So I definitely welcome any questions or feedback, and if anyone has any more specific questions about what's in the models, I welcome that. I just didn't want to overload you with all of the tables and everything, because I know no one likes to stare at a copy-paste Excel sheet. But I'll leave with that.
Sarah, so first kudos to you. You've managed to handle lots of data points, thousands and thousands, learn new methods, come up with some ideas how to think about it. So thank you for sharing. Can you go forward to the slide before last?
Oh, the slide before last.
Yeah. So when you are thinking about the transition variables, and you have defined them before, I may be oversimplifying, going from a child to an adult, there is the adolescent period somewhere in between. So help me understand, why not just using age as a transition? And I really like these transition variables in terms of transition of responsibilities, but help me understand why not just age as a transition variable as opposed to these functional ones.
Right. Well, age is included in the models, but why not just age? Because I guess my sociological response is that there are the timing of these things is probably one of the more important issues. So, again, the timing of marriage means different things for different people. It would mean different things for women versus men. And so kind of getting a better understanding, especially of questions that are sometimes recorded in healthcare information, and understanding at what age in the transitions do some of these things matter. Because one of the things I'm still curious about is are these risks set in stone in the first wave? I'm still trying to refine a way to look at that. I've done an interaction with age and race, and it's only significant for the other category. But I'm going to keep looking at those interactions as I refine models, because it would be informative but a little depressing if once I refine some of these variables, if that interaction is significant, because it would mean that this risk for unmet need would be established in adolescence and not be removed to adulthood. So that's some of the motivation is beyond just basic demographics. What are these things that occur in different stages in this time period that could be thriving or establishing unmet need at earlier periods.
So this is the final thing, and other question. So if that's which is a functional transition that may vary by the age of the person. If that's the case, you may want to think about how to reward the hypothesis 1 to capture what you just said, because hypothesis 1 says adolescence to adults.
Mm-hmm.
And to me, that's just a purely age transition.
Okay.
So just to think about to have internal consistency for that.
Okay.
Thank you.
Yeah, thanks.
So very nice presentation. I think this is really interesting, and definitely kudos for dealing with this complicated, figuring out how to deal with this complicated data set. So I had a question about your modeling strategy. So when you have the predictors in there, so say that you're looking at are you including the interactions with the wave in the models?
I did that in previous iterations of the model. I might need some help from Dr. Baker to answer why this isn't still in my model.
Oh, none of the interactions were significant.
Yeah.
Yeah, so it appears that like all of the characteristics are pretty much set in stone. Yeah, the unmet need transitions are set in adolescence as far as race and ethnicity is concerned in adolescent SES.
Yeah. And the tricky thing with using waves to analyze some things in this project versus age is that the gap in waves for some of the waves is like upwards of 7 years. And so then, a lot of things can happen in 7 years. And so I've been relying on age a little bit more to like show trends.
So I think, either an interaction either with age or with wave, certainly if it's not significant, certainly simplify your model, but if you don't have those, it means that your model will only give you parallel trends.
Right.
So just keeping that in mind as you do it.
Yeah, I did an interaction with age and the adolescent SES variables, and income is, like mother's income at wave 1 is also a strong association. So it does seem so far, but obviously I don't want to make a wide statement, especially as far as making a manuscript at this point say, these things are set in stone for the people with these characteristics. I want to dig in some more before I am confident in saying that.
And then another comment is when you're looking at, I think it's 2B, where you've got that sort of mediation hypothesis.
Mm-hmm.
There are, you might want to consider some analytic strategies to say percent mediation or other. That's sort of the simplest of the ways of looking at mediation, and at least, it's effective, but there are ways that are theoretically more complicated that may or may not be useful as well.
Okay.
Are there better formal tests of mediation you can do with GEE models?
Well, it's not GEE that's the problem, it's the survey weightedness. That is the whole problem with what to do with ad health. And honestly, I don't know if there have been adapted more sophisticated mediation techniques.
Than just say percent median. I didn't think so.
Well, when we first started talking about this, I didn't even think this model was going to run.
That should be my whole dissertation. We didn't think it was going to work, and it did.
So can you go back to the slide with smoking?
Just the trend line?
Yeah. So
Okay.
did this come from the raw numbers, or is this from the model?
This is raw. Yeah, this is raw numbers. This isn't from the model.
Okay, and it's the survey weighted adjusted frequencies?
Yeah. I was able to finally get the subpopulation to work so that any descriptive I do matches the N for the models.
And this is ever smoker, right?
Yes, ever smoker.
That still seems very high. That wave 4 variable is 45% roughly for the whole population.
Mm-hmm.
That seems very high.
Yeah, I might have scaled this wrong, honestly, since I was just working on it yesterday, but I'll take a look at it and see. The smoking rates in general are high for the population, but you're right, that does seem a little conflated.
Yeah, even wave 1, which is high school, it says it's 25%, which depending on what state these people are in, right? But they're all over the country. I don't know, it just struck me as being that rate being a little too high, but it is what it is, right?
Yeah, I'll take a look at it. I might have goofed on something.
How is ever smoker defined?
You smoked at least one cigarette a day for 30 days, or whatever that typical kind of question is. Yeah.
Because I think for adults, it's usually have you ever smoked at least 100
Yeah.
cigarettes? So it might be not quite comparable with adult rates.
Yeah.
Did you ever test an interaction with your transition variables in some sort of time, whether that was weight or age? Because that to me seems to answer sort of at least one of the big hypotheses you're looking at, which is, does an earlier transition versus a later transition seem to be?
Yeah, I don't think I've done that yet, and should definitely put it on my short-term to-do list. I'm hoping to make the transition variables better using principal component analysis, but I think interacting them with age would give a good idea of where they're going. So I should definitely do that.
Because I think just thinking about how you introduced the topic, which is pretty interesting, right? Of if this happens at 18 versus 25, what's going to be sort of more impactful for that? I wonder if that may help at least. And also for the record, I really enjoyed the large graphics and text and not having it.
Yes. I get a lot of compliments on my brain real quick.
For clarifying unmet need, wait from the beginning.
Yeah.
You have a need and didn't seek medical advice, whatever it was. Got it. I was intrigued by the going up, and one of the hypotheses could be there is increasing unmet need, as you're trying to tease out. Okay? Is there an alternative hypothesis? For example, we don't know what we don't know. If I smoke half a pack of cigarettes at age 16 and I keep smoking the same amount of cigarettes at age 22, and at age 20 I say, oh, I need to quit. But at the end of the day, there was no unmet need before.
Right.
And the behavior is the same. So is there any way to explore, tease out if this is just someone realizing that there is a need that they should have met, or this is a true unmet need increase?
That might be difficult to piece out with the data
I guess
available.
perceptive, or subjective versus objective.
Well, that's right. I mean, this is risky sexual behavior, the same thing saying, oh, by the way, I need to cut down or something. So.
Yeah. Well, so part of what I'm interested to look at in the cross-sectional analysis is because biomarkers are only available in wave 4, in wave 5, I'm using that, is that I can actually get an idea of what their health indicators are versus what they are assessing their health needs are. So, for example, their risk of high blood pressure. I remember because I looked at this a little bit in some of my thesis analysis, and at least a third of the sample was in pre-hypertension category in wave 4, but they're still rating their self-rated health. It's very good, and so it's this idea of, especially for the people who think they did have a need that didn't go addressed, what are some of their biometric health characteristics? So that I'll be able to get a snapshot of that in the cross-sectional analysis. That I think might help kind of address what I hear you saying of how do people even come to the conclusion that they have unmet need. But I don't think I can do it longitudinally.
Sarah, can you go to the bar graph? And can you just talk me through the interpretation of this one more time? Because I want to make sure that my interpretation is aligned with your interpretation.
So I kind of wanted to compare the effect of the SES and transition model to the effect of the health measures model before incorporating them in a full model. So you see that in the unadjusted model, all of the categories I've shown have increased odds of unmet need for healthcare compared to whites over time. When you add in SES and transition factors, that disparity decreases a little. And the same is true for health, but not to the same magnitude for blacks, for example. And so in the full model, you still see for blacks and Native Americans these increased significant odds of unmet need for healthcare despite health measures, despite adolescent SES, despite some of these transitions. But you do see the power of the effect removed for the Hispanic population.
Yeah, but I think if I'm understanding, like the general idea is, can we find either these transition periods as vulnerable periods for intervention or specific health-related factors that are driving some of this unmet need for these groups, right? So thinking about in the future, your findings informing action or intervention, it might be these life transition periods or these things. I guess when I saw this, even though maybe some of the significance changes, I was struck that the parameter estimates don't change that much. I'm wondering with confidence intervals how much change there is. So my interpretation was one of doing really elegant analyses and exploring these things. It doesn't seem that the life transitions or the measured behaviors are necessarily the main drivers. You know what I mean? So I guess thinking about for the future, what might be other drivers, thinking about, trying to, with either prospective data to capture, trying to understand, if we want to try to address this unmet need, it seems this might be giving us a little bit, but really there's a lot of something that's not captured that's really driving this, and what might that be, and how might we study that?
Right, yeah. The significant effect of the health variables especially is way more consistent than the SDS and transition variables at this time, partially just because all of the health measures are true waves 1 through 4, consistently measured variables. But also it might, not be an entire doom and gloom picture. It might be that the things that we already know are problems like adolescent smoking, we can identify as a risk factor for this as well. And so interventions for that, seem a little more silver lining than people of this racial ethnic minority population are at increased odds of this no matter what is in a model. So yeah, I'm trying to take a look at what are the actual actionable pieces of information coming from some of this data I've gotten.
What was the geography of this study?
It's nationally representative.
And do you get information about where people are?
There's a region variable, I'm pretty sure, that I've definitely thought about adding in at least. We have the restricted data, and I can't remember if that gives us, it doesn't give us any more specific.
No, for confidentiality reasons, yeah.
Yeah, so there's no way to, actually, plot where people are from or anything. But, yeah, there is a region variable, and I have thought about whether or not that would be worthwhile to include.
I think, particularly for the Native American population,
Right.
In the U.S., a lot of those people live in extremely rural, isolated areas, so, that might be part
There is
of
a rural-urban variable.
Okay, yeah.
That has been included, I guess.
Okay. Rural, okay,
Or
yeah.
size.
That would be easy to put into.
One of the things, this might be totally off base, I'm looking at my biostats folks. When I see these different states of unmet need, met need, married, not met, I think about some of these state transition type modeling approaches, and I don't know if that in the future would make sense for this data and your questions or not. But I've just seen some interesting thinking about when folks are transitioning from one state to another and multiple states, in the kind of Markov, kind of frame. And again, it might not be appropriate for this work, but when I see longitudinal state transitions, I know enough to know that's possible, and I don't know enough to know if it's dangerous or not.
I think one of the beauties of this data set is it's longitudinal and it has a lot of variables measured in it, but because you want to make statements that are not just about the people in ad health, you have to include all the survey terminology, and a lot of this stuff that you talk about, Markov modeling and those things, have not been adapted to survey methods. So you would lose the generalizability, but then you'd be able to talk about the transition, but there might be ways to adapt it, but I don't know.
I also wonder if you've got the granularity, right? Because if you know that they were married at some point in the 7 years, is that enough to really do that sort of transition? And you know that at some point they had unmet need, but you don't know when. I'm not sure.
That was the trickiness. Initially, I wanted to include pregnancy and childbearing, but one, the data set makes it very difficult, and two, I didn't know what it would potentially really say, because it asks it. I basically feel like I would have had to gender stratify the models at that point, because it does ask it gender neutrally. Have you ever gotten someone pregnant, or have you ever, partnered a child, or been pregnant or birthed a child? But you know, you might kind of be able to assume that if you were pregnant, you would be getting more health care than you usually would. And so in addition to the variables being inconsistent across the waves, I didn't know if it would kind of like conflate what I was looking at for like a total population. So at this time, I haven't included it, for example. But
Do you have information on actual transitions, like moves and job changes or employment variations?
so employment, I think, is asked in all 4 waves, but it's tricky because income isn't asked in all 4 waves. And so is that employment gainful? You know, like if you're in college and you're working, you know, at a pizza place, you know, it's probably not your like sole source of you know, it's different, like, because this transition is a time when a lot of people are changing in different ways. It's really hard to like stand by or assume that the usual markers we use for like SES, for example, like are going to even apply to them.
Well, I asked for a couple of reasons. One, so I worked on a project a while back where we interviewed these folks coming out of college and on chronic stresses and whether it predicted drinking trajectories. And folks are moving a lot and changing jobs a lot, and this time it changes your health insurance status and changes your access to all sorts of things. But so getting back to your like doom and gloom story, I think post dissertation you might have an opportunity to do some sort of multi-level modeling. Like, yeah, there might be some between person factors that kind of set your unmet need in stone, but there might be things that change people's trajectories, like having move or employment transition might increase unmet need. Marrying somebody who happens to be particularly health conscious might reduce unmet need, or I don't know, but down the line that might be some interesting things to look at.
Yeah, I think that's a good point of like the difference between like the person level factors versus like these external factors that I mean calling transitions, I guess, that could like potentially be influencing your risk.
I think along those lines, and I'm going to default to people smarter than me in the room, but I think some of the comments are sort of getting at what is inherent, like underlying unchanging characteristics versus what are things that change over time. And so, right, like I'm sitting here thinking of like risk aversion, and when you're thinking about unmet need and the way that question is worded, right, any sniffle and I'm the hypochondriac, that's like, of course I need to go see a doctor. And so you might want to consider like sort of an econ version of fixed effects where you put in a dummy variable for every person to take out this sort of unobserved time invariant bias of how that sort of stuff can be removed, and then what's time varying, and compare your estimates. And so I think part of what's happening right now is it's unclear, you know, in some ways, like the downside of that is for the things that don't change over time, we're not going to be able to get coefficients on race, for example.
Right.
But at the same time, I think being able to compare those two models side by side might also give you different insights as to things that change over time versus don't, and how they may impact on that need or are associated with.
Okay. Thank you very much.
Okay, well, so thanks everybody for attending today. My name is Matt Medford. The title of my talk today is Perceptions of Beta Blocker Use Among Adults with Heart Failure. So, for those of you who don't know me, I'm a PhD candidate in the Department of Epidemiology, and this is the second year that I'm on the T32 predoctoral fellowship. So my previous works and progress talks have actually focused on slightly different topics, so I just wanted to kind of give a recap on some of that. So The previous talks were on the association of hypertension, hypertension duration and control with incident heart failure. So we did this in the regard study, and we looked at this separately in black and white participants. And essentially our main findings were that hypertension is a risk factor for incident heart failure, but this was not different by race, which seems obvious, or in terms of hypertension being a risk factor. We also found that individuals who had a longer duration of hypertension and those who had uncontrolled hypertension have the highest risk for incident heart failure, and so this was compared to individuals with no hypertension. But we also found that even those individuals who had a shorter duration of hypertension or who had controlled their blood pressure also had an increased risk for incident heart failure compared to individuals who had no hypertension. And so this really gets at the idea of preventing hypertension before it even begins. So once an individual develops hypertension, even if they're able to control their blood pressure, they still have an elevated risk for heart failure. So your risk never really kind of goes down to those baseline levels where compared to an individual who never had hypertension to begin with. So we were looking at heart failure and this, and I'll back up a little bit just to kind of give an idea of heart failure. So essentially, heart failure is the inability of the heart to provide the cardiac output to supply the body's perfusion and metabolic needs. So you can see that in the middle you have a diagram of a normal heart, and heart failure really occurs by two main mechanisms. So you can see on the left-hand side you have a situation where heart failure with a reduced ejection fraction occurs, and this is essentially where the ventricular walls thin and weaken the muscles, and you get an enlarged ventricle. So there is a reduced pumping ability in this situation, and you're actually ejecting less blood to the body to perfuse organs during systole. At the opposite end, you can see we have a situation where it's heart failure with preserved ejection fraction. So this is essentially a situation where the ventricular walls thicken and the muscles stiffen, and while there's still a relatively normal, there's a reduced size, so you're actually getting less blood to fill into the ventricles, but there's still a relatively normal pumping action, so you're still ejecting a normal fraction of blood out to the body, what would be considered normal. And there are many signs and symptoms of heart failure, and it can make it really difficult to diagnose, but it's also equally difficult to treat. So this is a borrowed slide just to show you some of the main therapies available to treat heart failure. And this is split by individuals who have heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. So if you focus kind of on the top three therapies here, you can see that for individual, and these are from randomized trials where individuals were either receiving the treatments here, like beta blockers or ACE inhibitors, compared to some control group, and they were essentially followed for composite outcomes of morbidity and mortality. And you can see that for individuals with heart failure with reduced ejection fraction, there's a lot of evidence that these therapies are effective in reducing morbidity and mortality. So you can see for beta blockers, ACE inhibitors, aldosterone antagonists, all of these estimates here, these risk estimates show them favoring the treatment. But if you look over at heart failure with preserved ejection fraction, you can see there's not a lot of good options for treatment here. So you can see in a lot of these cases, the treatment was no better than the control group that was observed here in terms of outcomes. So why is this disparity important? Well, because we can have evidence over time that heart failure with preserved ejection fraction is actually increasing. So you can see this was from a study in 2006, New England Journal of Medicine. And essentially what it shows is that between 1986 and 2002, you have a relatively substantial increase in the prevalence of HFpEF. And additionally, if you look at the right panel, you can see that while hospitalizations for heart failure with reduced ejection fraction are relatively stable over time, there's evidence that hospitalizations for heart failure with preserved ejection fraction is increasing. and now the proportions of individuals with both HEP and HEFrEF are relatively similar in the population. And you can also see that in terms of mortality, there's while there's a slightly better survival benefit, or there's slightly better survival in heart failure with preserved ejection fraction compared to reduced ejection fraction, these differences are very small between these groups. So if we go back to this, for our analysis, we really wanted to look at perceptions of medication use in patients with heart failure, and we focused specifically on beta blockers. So beta blocker use in heart failure, it's guideline recommended for heart failure with reduced ejection fraction, and there's actually no guideline recommendation for heart failure with preserved ejection fraction in treating individuals with beta blockers. But there's evidence that despite being guideline recommended for individuals with reduced ejection fraction, their beta blockers tend to be underutilized, and this is by a combination of both patient and provider aspects. So from the provider side of things, individuals with heart failure have a lot of comorbidities. They're being treated with a lot of different medications, and so there's caution in terms of drug interactions. And additionally, from the patient side of things, often the immediate kind of effects of beta blocker use in people with heart failure are relatively bad, so that it makes them feel bad, and so they don't necessarily like taking them. But there's actually additional evidence that beta blockers in heart failure with preserved ejection fraction are relatively widely used. And this could also be because there tends to be a lot of overlap with comorbidities, including hypertension and things that would normally be treated with beta blockers. And so, we really wanted to get, because of the fact that there's pretty high beta blocker use among both heart failure types, but also, patients are taking a lot of medications. We really wanted to get at the idea of what are a patient's perceptions of their beta blocker use. So, do they know why they're taking their medications, and additionally, what patient factors are associated with perceptions of beta blocker use. So we used the regard study for this, and for those of you who've been in my other talks, I've talked extensively about the kind of makeup of regards, but just briefly I'll go over it. So it's population-based cohort, nationally representative, of black and white individuals who were 45 years of age and older when they were enrolled. You can see that the population distribution is here. There's some representation in each of the 48 contiguous United States. And because the original idea was to look at regional and racial disparities in stroke risk, you can see that black individuals were oversampled, so there's roughly equal proportions of blacks and whites. And additionally, for the regional disparities aspect, participants were oversampled from the southeastern United States with respect to the rest of the United States. So this is a kind of a flowchart of how our participants fell into this analysis. So regards participants are older when they were enrolled, and we actually have the ability to link a lot of them to their Medicare claims. So for this analysis, we used participants who we identified as having heart failure based on Medicare claims, and in conjunction with the major second in-home examination in regards, participants received a medication use survey in 2016. So you can see this was administered to about 1,100 individuals, and we had 518 respondents to this medication use survey. Among those individuals, about 70% reported taking a beta blocker. And so among those, we asked questions about, why do you or did you take your beta blocker? And so among the participants who responded to this question, we had an analytic sample of 357, but we wanted to look really at kind of differences by type of heart failure, so HEFrEF and HEF. So we split those individuals here. So we have 124 with HEFrEF, 78 with HEF. There were additional adults who we had an undetermined ejection fraction. For the purposes of the results I'm presenting today, yes?
Go ahead.
For the purposes of the results I'm presenting today, we're just focusing on the two types of heart failure, but we did do additional analyses where we looked at all heart failure combined.
How was that determined? Which category of heart failure they fell into?
So we categorize this based on ejection fractions through.
Was that recorded in the in-home visit?
So this was through the records for heart failure hospitalizations that we identified. So they were adjudicated from the medical records.
So I'll add so most of them, so to identify heart failure, was either the adjudicated hospitalizations where we have medical records or Medicare claims, and some of the Medicare claims have ejection fraction information coded into them, so it's some combination.
So, so you can see, compared to what I've worked with in the other analyses where we're dealing with, 20,000 plus individuals, here we have relatively small numbers. So there are some inherent limitations with these are small samples. Beta blocker use. We asked the question, why did you or do you take beta blockers? And there were a number of response options. So this included to reduce blood pressure, to reduce the workload on the heart, to treat heart failure. We additionally, participants could respond that they didn't know, or if they had some other thought on why they were taking their beta blocker, they could respond to that as well. So again, just focusing on HFrEF and HFpEF, we just have some of the participant characteristics here, and these are characteristics from the second in-home examination in regards. So you can see that all the participants are older age. A higher proportion of participants with HFrEF were male compared to those with HFpEF, and there was a roughly equal distribution of race across the two types of heart failure. You can see most of the individuals had hypertension, and then you can see about 44% of individuals with HFrEF had a hospitalization for heart failure, while about 40% with HFpEF did have a hospitalization for heart failure. So what did the responses to this beta blocker survey look like? So there are a couple of things to point out. So you can see here a higher proportion of individuals with HFrEF reported taking a beta blocker to treat heart failure. Only about 20% with HFpEF identified beta blockers to treat their heart failure. While there was a relatively high proportion of both types of heart failure that reported taking their beta blocker to treat high blood pressure, you can see a higher proportion of individuals with heart failure with preserved ejection fraction reported this response. And I just listed some of the other responses here, which you can see, relatively small, but a proportion didn't know why they were taking their beta blocker.
Ma'am, did you allow them to answer more than one?
Yes.
Okay.
Yeah. So participants could respond to more than one response here.
Can I ask another question?
Sure.
Sorry, I keep interrupting. Just out of curiosity, how was this asked? Did you show them their medicine, or because if I asked half my patients why they're taking a beta blocker, they don't know which one that is.
Yeah. So I know that it was administered during the second in-home exam, or yeah, I may need a little clarification on that.
So we gave them a list of beta blockers, the generic and the brand names, and so these are the medications.
They picked the one that they were taking in the age.
Well, so we didn't actually ask them to pick the one that we were taking, but when we piloted this, so we piloted this at UAB at one of the outpatient clinics, and people were actually circling the one that they were taking, which gives me some, I would say about half of the people who said, yes, I'm taking a beta blocker, circled the one that they were actually taking, so that made me feel a little bit more confident that they were
wondering.
Yeah, that is certainly a limitation though.
Yeah, I just wonder if they actually have done it during the field water review, because in the way how they've done during the home visit, they actually take all the fuel bottles from the cabinets and they go one by one. I wonder if it was kind of in conjunction, then it makes more sense.
Was it done at the home visit though?
It wasn't done at home.
No, it was a no survey. But we could actually.
There was no telling what they thought that was.
My patients know medications by the color and the size of the pill.
Yes, absolutely.
So we can look, because we do have the in-home visit data, we can actually look to see, it's not going to be perfect because we asked historical, and so the in-home visit is a snapshot.
You get a sense at least.
So I'll start here with this blank table. Again, we're dealing with really small sample sizes here, and so when I present like the factors associated here, I'm just going to present the general direction that we were seeing these associations, because the confidence intervals tend to be quite wide, and so I don't want to fixate on that too much, because there's certainly a lot of imprecision with this. But we use logistic regression here, so these will be odds ratios estimates that I'm reporting. So among individuals with HFrEF, what factors were associated with responding that they were taking a beta blocker to treat heart failure? So for this, we didn't see a lot of signals. What we did see is that there was a relatively higher odds of reporting this response among individuals who actually had a heart failure hospitalization. So when we look, again, among HFrEF, what individuals who were responding that they took their beta blocker to treat high blood pressure? Well, not surprisingly, there was a much higher odds of this response when an individual had hypertension compared to no hypertension. And more interestingly, if we look at the HFpEF side, we didn't see a lot of signals here as well, again because of the sample size. But what we did see is that black versus white race was associated with a higher odds of reporting taking a beta blocker to treat heart failure. And in contrast, there was a much lower odds of responding, taking a beta blocker to treat high blood pressure among black individuals compared to white individuals. So I'm still trying to wrap my head around some of these results here. Some of the takeaways from this that I have at least interpreted is, of course, having a heart failure hospitalization potentially results in patient interactions, which facilitate a better understanding of the heart failure specific uses of beta blockers. However, if you look at black individuals with HFpEF, these individuals are less likely to report beta blocker use to treat their high blood pressure, which makes sense since there's a relatively poor response of blood pressure control for beta blockers in black individuals. And they were also more likely to report taking beta blockers to treat heart failure. So, without making too many big assumptions because of the inherent limitations, essentially this is a situation where, we know health literacy overall is relatively low in terms of medications individuals are taking. So this is really a call for, better patient education when there's encounters with a provider or physician to really, kind of convey to an individual like what medications they're taking, in particular for a condition which has such a poor survival associated with it. These individuals really need to understand the heart failure specific uses of their medications. So some of the next steps for this, obviously this manuscript needs to be fine-tuned a little bit. There may be some additional work that needs to be done. And this is also being incorporated into my dissertation. With that said, I am going to be defending this semester, so I'm starting to think of next steps after this. So in particular, how does this work and previous work that I've done adapt to electronic health record data? One of the interesting things maybe to look at as next steps for this project is how does polypharmacy or different types of provider interactions impact these results. But additionally, I've done work looking at statin use, I've done work looking at cognition, CKD, and so really trying to think of how to adapt some of this. And that really leads me to kind of my last point, is because I've actually accepted a postdoc position, and I'm going to be working with electronic health record data kind of exclusively after this point. Yeah, really kind of gearing towards fine-tuning this project, as well as getting my final dissertation document complete, and then, yeah, I'll be transitioning to EHR.